So yeah, I'm Kate Warren. I'm a consultant in public health in Wolverhampton. Jason is on the call, I think, but he's kindly allowed me to do all the talking. So thanks, Jason. But I'm sure he'll be able to answer any questions if there's anything specific about the analysis that you've done. This work was done under the Royal Wolverhampton Trust's Health Inequalities Steering Group. So we're quite unique for public health team in that we work for the hospital trust in Wolverhampton. So it's actually the Trust's Health Inequalities Group that kind of commissioned this piece of work. So the context, as you mentioned, Rachel, is that there have been a couple of regional reports. So Steve's was one, and then I think there was a report produced by the Black Country ICB BI team as well, looking at elective care and the sort of waiting times for treatment, inequalities in receipt of elective care. And these reports had highlighted some disparities across different population groups, so in particular ethnic minority groups and deprived parts of the population. And Steve's report had really sort of highlighted the fact that when resources are more constrained, those inequalities can widen, and there'd been a trend over recent years that had shown that was the pattern. Sorry if I haven't summarised that very effectively, Steve, but that was the sort of one of the main messages that we took away from things. So it was a sort of word of caution, really, that when things are very busy, we have to keep an eye on health inequalities to make sure that they're not getting worse, because that's the tendency. We also took away from the report the fact that it seemed to be, from examining a few kind of discrete pathways, and I think hip arthritis was one and COPD was another, that there wasn't necessarily a problem of getting people into secondary care, i.e. GP referrals were possibly sort of representative of what could be expected, but that once people had got into secondary care, then there seemed to be a bit of a gap by deprivation for those who actually went on to receive more specialised treatments. So there was a very helpfully sort of laid out pathway from all the way from identification of a problem all the way up to the actual receiving the actual treatment. And the report had gone through various stages of this pathway where those disparities could be introduced and what sorts of factors might be contributing to that, and where we could potentially look in more detail to find out what was exactly happening in our local system. So that was really helpful. It gave us a good pointer as to where to look. But I think with all of these kind of reports, when the data is quite high level, you then have to sort of think, well, does that hold true for our local data, and how does that look in our trust? So we wanted to do a bit more of a deep dive into our local context. So our first port of call is to look at the referral to treat dataset. I'm hoping that most of you will be familiar with this, but essentially, for those that aren't, it's what's called clock stops data. So when a referral is generated into secondary care, a clock is started. And when somebody either receives a kind of decision that they need a treatment and is listed for that, or when they have a decision that they're not going to receive treatment for whatever reason, or if the patient declines treatment, if the patient dies, or if there's a start of a process that's called active monitoring. So you decide, well, we may not need to give you this treatment right now, but let's keep an eye. And the only other outcome is if the patient DNAs multiple times, they're discharged back to the GP. So these are the kind of endpoints, what we call clock stops. So there's a data set that's produced to enable monitoring of those waiting time to the endpoint, essentially. So the endpoint is not always treatment, but we do still keep an eye of how long those pathways take. So when we looked at the RTT data set for our trust, this group that we've highlighted here in red, the DNA group, was of particular interest to us because the regional reports had highlighted DNA as a potential kind of source of delays, of inequalities, and the BI report in particular had highlighted that for people who did have DNAs, the waiting times were longer. So we wanted to look a bit more in detail at this group, and using all the demographic information about the referral that we'd got in the data set, we carried out a regression model to see which factors were associated with this particular outcome. So just to mention, if you DNA your first appointment, in other words, if you don't engage with secondary care at all, you're not included in this group. This is for people who've initially engaged, but then had repeat DNA outcomes for their appointments, so kind of dropped out of engagement with the secondary care pathway. And when we looked at the factors that were associated with DNA due to multiple discharge due to multiple DNA, sorry, we found that there were demographic factors associated with this outcome. So ethnic minority groups, except for Asian, people under 50 years of age, men and people living in the most deprived quintile were all more likely to be discharged due to multiple DNA than the sort of reference group. I'll show you the sort of output from that model on the next slide. We then looked at for people who go on to receive treatment or a decision about treatment, so they don't drop out of the pathway. And we looked again at a sort of regression model of which factors were associated with waiting times for those groups. And for those people who do reach the end of the pathway, don't drop out, we found that clinical urgency and whether the procedure was inpatient or outpatient were the main driving factors in determining waiting times. So we didn't really see any clear trends related to demographics for people who do go on to get to the end of that pathway. So we felt, after having looked at these initial areas, that we really wanted to focus on reducing non-attendance and therefore reducing the proportions in those demographic groups that drop out due to repeat non-attendance. So that was where we decided to focus. I hope that sort of rationale makes sense. And here, just to illustrate a bit more visually, we did a heat map of non-attendance. So this is DNA for outpatient appointments broken down by, we've got on the left here, IMD decile. So 0 to 19 being the most deprived group. We've also got age across the top, and on this second chart, we've got ethnic group across the top. So you can see here, there's a clear gradient within groups as well as between groups. So even in the oldest age groups, which have relatively good levels of attendance, there's still a deprivation gradient. Even within ethnic groups, there's still a deprivation gradient. And, you know, even within deprivation quintiles, there's still an age gradient. So these things are sort of multifactorial, and we talk about intersectionality when we refer to health inequalities. So it's not just one factor, but there are multiple factors. And if people have got, you know, kind of multiple challenges, then it's going to increase their likelihood of disengaging. We also noted this is an interesting pattern, because quite often when we hear about inequalities analysis, we hear about BME or BAME or ethnic minorities all kind of being talked about as one homogenous group. And actually, in Wolverhampton, we rarely find that to be true. We tend to see this pattern quite commonly, that the outcomes for the white ethnic group are virtually the same as the outcomes for the Asian ethnic group. And I think this obviously will depend on local context, because in Wolverhampton, we've got a relatively well-established Sikh population. You know, there are second, third, fourth generations of Asian families that have been living in the city. And now, you know, lots of people from Asian ethnic group living in relatively affluent parts of the city as well. So it doesn't necessarily hold that somebody's ethnicity determines their outcome, is the point that we're trying to make. There are other factors involved. So affluence is, you know, obviously a protective factor, but I think there's other elements of culture and migration and other factors, education, for example, that come into play, and not just somebody's ethnicity. So that's just an interesting nuance to point out. So here's the outcome of the regression model, in case anyone's interested in the detail. But what you can see here, again, visually, is quite a clear age gradient. So you're less likely to drop out if you're older. As I said, Asian, there's no difference between that and the reference group, which is white. There's quite a clear deprivation gradient. Here we can see relative to the most deprived group, you're less likely to drop out if you're more affluent. And then we did also see some effect from some of the clinical factors. So if you've been referred as an urgent referral or on a 2-week wait pathway, you're less likely to drop out, which kind of makes sense. You know, perhaps you might be more sort of concerned about the reasons for referral and therefore more likely to attend. So off the back of this finding and this kind of conclusion within our steering group that we wanted to focus on non-attendance, we went back to Steve's report and looked at what the kind of strategy might be for addressing this. And there's this very helpful table in there that kind of breaks down each of the stages of the pathway and makes some kind of suggestions as to how you might, I suppose, stretch the amount of attention that's placed on each of these stages. And it's a sort of menu, really. Steve suggests that you could sort of pick and choose depending on what you think your local important factors might be. You could pick several of these, or you could focus on one particular aspect of care, and that you might look at tailoring the kind of response depending on the level of need in the local population. So what we looked at in particular was appointment reminder systems and transport support. We looked at these other areas within the pre-admission assessment and management section, but there wasn't really scope at the time of delivery to address things like out-of-hours appointments and virtual appointments. The infrastructure and the resource wasn't in place for us to be able to adjust those things, whereas we felt that appointment reminders and transport support we could provide additional support with. So the plan was to focus on deprivation deciles 1 to 4, because when we looked at the sort of drivers of those demographic drivers of inequalities, we felt that deprivation was quite a clear one that stood out and would be relatively easy to identify on the waiting lists in order to offer sort of more tailored support. So we were going to pilot this approach, taking a kind of universal, oh, I've just lost a view of my slides. I'm not sure if they're still up for you. Hopefully they're still up for you.
Oh, hang on. I might have said that too soon. Might have to
Can we still see them?
It feels like they're going to come back. They are. There you go.
They're back. Okay.
Yes.
Sorry, I think my computer decided to randomly do some updates or something.
Blame me.
So we decided that what we would do is an additional support offer for deprivation deciles 1 to 4. So we still have the universal offer, which is the letter and the text reminder that goes out to everybody. But then we would add on additional support for deciles 1 to 4, which would take the form of a phone call, offering support with things like transport and any reasonable adjustments for disabilities, interpreting, etc. We also sort of asked around within our outpatient teams and within our patient access team to find out whether anyone within the trust had already done this kind of approach. And it was felt at the time that although there have been lots of attempts to reduce non-attendance, it's kind of, you know, constantly an issue for the NHS, isn't it? So there've been lots of initiatives previously, but they'd all taken a universal approach. So it had been a one size fits all. We're going to try text reminder, for example, but there'd been no tailoring depending on sort of risk level for attendance. So there is a possibility, this is the danger when we do universal interventions, that actually inequalities are widened because the people who are most able to respond to that intervention are more likely to be those ones in the most affluent groups or the older age groups that are more likely to attend anyway. So there'd been no monitoring of the kind of response to the intervention previously by any demographic. So we were really keen this time to get that data collection right so that we could actually monitor the response to the intervention. Right, so the actual intervention itself, I've put a pragmatic intervention in the title section because this wasn't a kind of, you know, gold standard clinical trial kind of scenario. This was really what can we do quickly, what can we do within current resource, what can we do practically that's going to try and, you know, be able to make a difference to the patients that we've got on our waiting lists now. I think if we were to design something gold standard, it would have taken a lot longer and we probably wouldn't have been able to get the resource required to deliver it. So we had to do what was pragmatic for us at the time, and this did subsequently generate a number of issues, which I'm going to come back to later when we talk about lessons learned. We generated a script and a data collection tool based on some pilots that had been carried out in other areas and shared on a national forum. So we adapted those for our local use, and we asked members of our patient access team to carry out the calls. So these are the people when you get an outpatient appointment through and it says, you know, if you need to rearrange, please call this number. This is the team that deal with those calls and can reschedule, cancel, make amendments to clinics and things like that. So they've got access to that system. And if they were on the phone with people, they'd be able to make those adjustments there and then. So we felt that was a really good way of dealing with it. They wouldn't have to then get back in touch with the person on the call. They could do it while they were speaking to them. We pulled clinic lists about a week before the appointment was due to happen to give chance for people to, you know, make any arrangements for things like childcare or getting out of work or whatever. So it wasn't like ringing up the day before. We gave them a bit of a slightly more advanced notice. We also made calls out of office hours because we felt that, you know, perhaps if people were working, they wouldn't have the opportunity to answer the phone. So some of those calls were made on Saturdays and some were made in the evenings. And we also checked that they would be made from a local landline number so that those would show up on the phone as a, you know, an 019, which for some people I know get blocked. So we tried to anticipate as far as possible any problems that there would be with people being able to answer the calls and mitigate for those in advance. And here's the sort of flow chart for the script that we shared with the staff who were making the calls. So as you can see here, you know, if there was any opportunity to discuss concerns that this person had got in being able to attend or access the appointment, they'd got a whole pack of information available to them when they were making the calls about how they could offer support with things like interpreting, transport, being able to move the appointment to the start or end of the clinic, any concerns about mobility or sensory impairment like accessibility information for the clinic, etc. So they got all that information to hand. So just moving on to show you some of the data that was collected as a result of the intervention. So first of all, just in terms of actual numbers of patients involved, this is the breakdown by IMD decile. So most deprived 4 deciles over here, which was our intervention group, and least deprived 6 deciles over here. These are the people who just got the standard letter and text reminder, but didn't get the additional phone call. So because in Wolverhampton we're a relatively deprived area anyway, although we've got 4 and 6, it worked out fairly even numbers. And this is just to show the number of calls that were made. So we did make up to 4 attempts at calling if there was no answer or if we couldn't get through. Although in most cases it didn't take 4 calls. Oops. And this is just the percentage of the total number that we actually managed to speak to. So the majority, about 65-ish percent, we actually spoke to on the phone. About 20% we were unable to reach. So that would have been, you know, if it goes to voicemail or the number was blocked, etc. And then just less than 15% were not contacted. There were also, just to say at this point, because some of you might be realising that these percentages aren't adding up to 100, there were also a number of outcomes that were quite difficult to categorise. The data collection wasn't necessarily good enough for us to be able to clearly categorise people into one or other of these boxes. And as I said, I'll come back to that at the end in terms of lessons learned, but there were some data quality issues, it's fair to say. And then what we've done here is shown the DNA percentage. So we did follow up to see whether people actually then attended their appointments. So the people that we'd spoken to and said they were going to attend, their DNA rate was less than 10%. For people who their appointment date was before we attempted to make contact with them for one reason or another, they didn't get round to calling in time. Again, their DNA rate's about 10%. For people who didn't answer the phone, their DNA rate was above 20%. And for this group that weren't contacted for one reason or another, their DNA rate was the highest, over 25%. Due to the data quality, in some cases, it's not entirely clear the reason why this group wasn't contacted. And I think that, you know, in retrospect, we would have liked more detail on why they weren't contacted. But some of that could be because they didn't have the contact information, they didn't have the phone number, or possibly that the records were incomplete or that the number was blocked. And then we did also just have a little bit more of a delve into these groups by demographic groups as well. I mean, we're getting into small numbers for this not contacted group, so we have to sort of look at this with caution. But we were just sort of trying to get any more insight as to, you know, what these groups looked like in terms of demographics and whether there was any trend within the groups. So so the main thing that stuck out for us really was this group that we were unable to get hold of. There was a trend even within deciles 1 to 4. So the most deprived most deprived 2 deciles 1 and 2, had a much higher DNA rate than deciles 3 and 4. So that was even within the intervention group, there was still a trend by deprivation of people that we couldn't get hold of, essentially. As I said, this group is small numbers, so I wouldn't necessarily read too much into this, but there didn't seem to be a massive disparity by ethnicity within the intervention group. And we did see a bit of an age trend as well, which we expected, that people who were over the age of 60 were less likely to DNA, even within the intervention group. So this is a sort of summary of our final results. So the blue the blue bars on here are the overall patient group that we did the pilot with, and the grey bars are the a similar sort of matched group from the previous year of the same clinics. So we went through and basically tried to replicate the clinic groups with a similar cohort from the previous year as a sort of control group, really. And what we saw was that there didn't seem to be a great deal of difference, really. So Jason actually carried out the relative index of inequality, which is a methodology that Steve had recommended in his report to be able to report on inequality by deprivation. which looks at the trend across the whole deprivation spectrum and summarises it really in one figure to give an indication of how much of the difference is due to deprivation. And there wasn't really a difference between our pilot group and the control group. So the conclusion here is really that our pilot didn't have an impact on inequalities by deprivation, which was quite interesting given that, so just looking back at the sort of breakdown, when we first looked at the data for this group that we'd managed to contact, their DNA rates were lower than what we would have expected based on the previous year's data. So I think there's a lesson to be learned here, because when we looked back at some of the case studies that we based our proposal on, actually what they had reported was this group here in blue, the group that they'd actually been in touch with. So their denominator was people who they'd spoken to on the phone, and they compared that to a control group from, you know, last year or similar clinics or whatever the control group was. And they didn't report on this group here, so people they hadn't managed to get in touch with, which I think is misleading because it's not taken into account the ability of the intervention to reach the target group. So when we actually did a kind of evaluation that looked at that whole group, not just the people that we'd spoken to, we found that there wasn't a difference. So although our results were consistent with those other case studies, the way that we'd reported it and using the relative index of inequality showed that it didn't reduce inequalities. So to kind of sum up, I hope that's all sort of made sense. I think the main challenges that we found with this were, as I said, you know, numerous times, the poor data quality, because we had to rely on existing staff and existing processes to deliver the intervention. We didn't have too much control over the quality of the data collection. So we did design a template, but it wasn't necessarily populated very well. There was lots of kind of free text comments added to the template and things, rather than people using these sort of pre-designed categories. And I think the main problem with this is that you can't publish your results really if the data quality is poor. You know, if we tried to write this up for publication, we would struggle ourselves in being able to exactly say how we'd categorise things into groups, because some of it was a sort of a judgment call based on those free text comments and what we thought was the most likely group that those people should be put into. So it was difficult because there were communication barriers between you know, us as, well, you know, analysts. I wouldn't necessarily put myself in that group, but the people who were doing the evaluation and the people on the ground who were actually delivering the intervention, because we were working sort of through managers and through other project support staff. So if we'd have been able to sort of directly speak to the people who were making the calls and explain what we needed from them in terms of data collection, that might have mitigated that a bit. But I think just because it was existing staff doing overtime, working at the weekend, and, you know, we didn't necessarily want to put too much pressure on them, it did result in poor data quality. So the result of that is basically this isn't going to be good enough to publish in a peer-reviewed journal. And I think this is perhaps a common problem, that where pragmatic interventions like this are conducted, that they're often not published because the data quality isn't of good standard, but they can be published in, you know, these sort of informal case studies that are then shared on websites and in national networks and on, you know, like the knowledge hub kind of websites. So I think the other thing that we learned was that you need to be quite careful when taking results from those kind of case studies, because people aren't always necessarily 100% upfront about their data quality. And in a lot of situations, the case studies are only shared when there are positive findings. So, you know, we talk about publication bias in formal literature, but I think there's probably publication bias in this sort of grey literature as well, because people aren't going to be as forthcoming in sharing case studies where things haven't worked. So that was why we were particularly keen to share these results today, really, just to be honest and upfront and say, actually, we tried something, it didn't work. But we think that it's equally as important to share this as it is to share something where it has worked. The other thing to just be aware of with the literature is around the context. So we did look at a couple of articles that have been published that said that shared, published findings where interventions like this, telephone reminders or telephone interventions, had been successful. But when we looked at the detail of the literature review and those studies that had been cited, they were actually based in primary care. So for things like cervical screening appointments in primary care, if you can't attend the appointment that's been booked for you, you can probably move that appointment to a time that works for you. And there's probably more flexibility within primary care to offer appointments at different times of the week. Whereas in a secondary care setting, if you've got an appointment for, say, a diabetes ophthalmology clinic, that clinic probably only happens at one time of the week. And if that happens to clash with your work, for example, then the chances are that you're not going to be able to have it on an evening or a weekend clinic. It just, it has to happen at that time of the week. And if you can't attend, you can't attend. So I think context is really important in understanding findings within the literature as well, which I suppose leads on to the final point, which is within the scope of delivering elective care in an NHS trust, there is a limited amount that we can actually do in terms of being flexible with things like this, in being able to mitigate inequalities. If somebody works shifts, or they're on a 0 hours contract, or they've got childcare responsibilities, or they're a carer for a relative or something like that, and they're having difficulties getting to appointments, there's not a great deal of flexibility in how we can offer the service to be able to cater to those kinds of needs. So I think the ability of an NHS trust to therefore mitigate inequalities is relatively small compared to interventions that would tackle the root causes of inequalities in the first place. So it's been quite an interesting case study for us to reflect on internally within the trust and think about where we can actually have a difference, make a difference, and the sort of limitations of our impact on health inequalities within elective care. So I'm going to stop talking now, I'm losing my voice anyway, just to give a shout out to Jason, Carla, Karen, Daniel, and the teams in ophthalmology and patient access who carried out the intervention. And I'll stop there and happy to take any questions. Thank you.
Thanks, Kate. That was really interesting. I've been looking forward to hearing about that, and totally agree. It's really important to share the results, whether they're good, bad, indifferent, because that's how we learn from what other people have done. Look at everybody clapping their hands and they're saying thank you very much, Kate. Yeah, so I would I think we do have I think Janine, you made a comment in the chat. I don't know whether Kate's covered it because you mentioned it a little bit back. So in the comments, Janine was saying, have you done any follow-up work or qualitative analysis of the cohorts with higher DNA rates to understand the reasons for the differences? She also says fab work, and can we have a copy of the slides?
Yeah, of course, I have to share slides. And I think as well, Steve, we did discuss previously perhaps writing this up to put onto your website. I'm really sorry, my door has just gone and I am expecting a parcel. I know it's really embarrassing, but can I just nick 20 seconds and I'll be back?
I literally cannot say anything. I was just like almost 10 minutes late for my meeting.
Can I just take this opportunity to say that I don't have access to the chat. There may be other people, but Menti wasn't shared earlier to get questions out, and I'm all right speaking, but I don't know if everyone really wants to do that.
So if people do want to, well, Kate's back now, and Steve's going to say something, but I'll make him wait. If people would like to put a question on Menti as opposed to shouting out, or if they can't see the chat, the code for Menti is 79970299, and I'll just say that
could you do that again?
Yeah, sure. So it's 7 7997. So that's menti.com 7997 0299. Has that landed? Yes. Okay. Yeah. So yeah, normally I would we would be sort of in Menti and sort of putting questions on there, because Kate, only about you probably heard me say it a million times, about half the people can see the chat and half the people can't.
Yeah.
So we put the Menti up so people can. So Stephen, you got your hand up.
But shall I just answer the first question that
Sure. Yes.
was interrupted by the Royal Mail? Sorry.
Sure.
So regarding the qualitative feedback, we didn't carry out qualitative feedback as part of this project, but what we did do, which I didn't mention in the slides, was as part of that kind of asking around what had already been done, we did identify a couple of pieces of work within the trust that had been done previously that had included qualitative feedback. So one was an audit of glaucoma patients with non-attendance, and one was an audit of diabetes patients who'd not attended. I think they'd faced similar issues in terms of being able to actually get in touch with people, was the first thing to mention. So I think some of this feedback was relatively limited. What had come out in terms of trends and themes, I'm just trying to sort of remember the summary, was that there were a fair few patients who had said that they didn't have the details of the appointment. So there were some administrative problems, I think. And those were from the people who'd done the audits. I think some people had said that they were a bit suspicious as to how much of that was actually true, that they literally hadn't got the details of the appointment, or how much of it was they'd had the details but forgot to kind of put it in their diary, or just forgotten about it. Whereas some of them were fairly confident that the letters just hadn't gone out. There were actual administrative problems. Another group was people who didn't want the appointment but just hadn't cancelled. So they didn't feel the need, perhaps their problem had resolved, or it was like a routine follow-up that they didn't feel they needed, but that they'd either not bothered to cancel or they just couldn't get through to cancel. And then I think a third group was people who had kind of medically related challenges. So that's quite a broad group, but by that I mean things like they were in a care home with mobility issues and there wasn't somebody to accompany them to the appointment. They become acutely unwell with something else unrelated to the problem, but weren't able to attend on the day because they were poorly. They had got mental health condition that was making it very difficult for them to attend. So there was sort of mixed bag of clinically related factors for some of them as well. So, as I say, I think probably the people that they didn't get through to in terms of being able to provide feedback as well are another group who are totally unheard from. But we suspected that there were probably other logistical challenges. Just looking at the trends in attendance and the fact that younger adults and people from deprived areas are much less likely to attend, made us think that there were just logistic problems with being able to get out of work or childcare commitments that make it harder for people to attend, which are very understandable. But yeah, so in essence, we didn't do qualitative feedback as part of this, but we did kind of try and collate some of that insight before we did the intervention. And I think, as I said earlier, some of those are very difficult to tackle. There's not a lot you can do about non-attendance in some cases. You can, I think, make it as easy as possible for people to rearrange or cancel. And we know that we've got some administrative challenges in people being able to literally get through on the phone to do that. So I think those are perhaps the areas that we could make improvements, but that doesn't necessarily mean that the person's going to be more likely to attend. It probably just means they're more likely to cancel or rearrange.
Okay, thank you, Kate. Steven, do you want to come in now?
Yeah, although Kate's just answered my main question, I think. But well, first of all, I want to say thank you, Kate, for presenting. It's so sort of I don't know, encouraging, uplifting to hear what is a really serious attempt to tackle a problem it's so easily to be overwhelmed by this problem, isn't it? But you can only pick it up and try things, and when you do it seriously and as best as you can. So it's great to hear the story, and also the sort of humility and honesty and transparency with which you told it. It makes it. Thank you for that. Really appreciate it. Thank you. Yeah, I mean, my question was going to be about because in some ways that the conclusions could be a bit dispiriting, can't they, I suppose. But we've got to. I think we've got to try and keep trying to find ways of addressing this problem, haven't we? I think we can acknowledge that it's difficult to mitigate the challenges of the inequalities we see, but I don't think we can give up on them as such. Or I don't think we can also just kick it back down to the sort of preventative route. That's definitely that shouldn't be an either or, should it? But I guess it's okay to say that you've got to come up with the ideas for the interventions that could make a difference. Just wanted you to reflect a bit more, ask for your reflections a bit more on that group that you couldn't contact. Are you sort of are you reaching the view that even if you could have contacted those people, the intervention would not have had an impact? That hard to reach group that had higher DNA rates. Is that? I'm not forcing you to say definitively. What's your view on that group?
Yeah, I wouldn't want to assume, to be honest, Steve. I think we just have to be quite honest in saying that we don't know. That there's likely to be, as I say, a mixed bag of reasons why people don't answer the phone, why people don't attend appointments, and that mixed bag is going to be bigger in an area like Wolverhampton. I think that's all we can say, really. And I think I always say this when we talk about inequalities, and there seems to be a lot of pressure. I don't know if other people feel the same, but a lot of pressure from, perhaps from execs or from national bodies or whatever, to kind of come up with an answer to tackle inequalities, when really you need like 100 different answers. It's probably a case of chipping away at lots of different things to a small degree, as opposed to having one big thing that that results in a big difference, because it is multifactorial. And if there was an obvious easy answer of making a big difference, we'd all be doing it already, wouldn't we? So I think it is a case of just repeating the process, thinking again, trying something a bit different, trying to perhaps we try a postal intervention. There's problems with resource. We literally haven't got a budget for this work. That's the other issue. So the telephone intervention was, as I say, pragmatic because we had staff. But to do anything else, we would need additional resource, which isn't available. So there are so many barriers to get over. That's the reality. But as I say, we won't stop. We'll keep looking at the data, keep refreshing, keep talking about what else we can do. The sort of route that we're taking at the moment is around staff training and education, and working with teams like the quality improvement team, trying to make this an aspect of medical leadership, so that the teams and departments can try and factor this into the way that they set up clinics, the way that they set up their admin processes, all those kind of factors, so that we make it a bit more distributed. But it is really difficult. I can't make it any plainer, really. It's a battle.
Yeah, thank you.
Thanks, Stephen. Kate. Zoe.
My question is back to the data, really, because as you have quite rightly said, and it's great analysis, you're chipping away, and it may be that those interventions may not have worked in that geographical area or for that particular service, and it may work in other areas, and we don't know, because from an analyst point of view, from my point of view, I'm relearning every single time. So I was wondering if there's any way that we could get, maybe not necessarily code, or the outputs that you've produced, but the format and the methodology, like the analysis plan, and it may be retrospective, but for us to then have that as well as the findings, which is the publication bias that you're sort of tackling, which I think is amazing as well, because we do have that opportunity to publish things that say this didn't work, but that we can reproduce those in other areas more quickly. And I find that just as an analyst, you know, you're given some work and you're like, well, this is the first time I've ever looked at this. Where do I start? How do I do this? And so we're always building on things, which you referred to Steven's work, which is great. But if we, because what we're trying to do in the Midlands Decision Support Network in a bit of an area, and I'd really love to be able to connect with you and maybe bring other people in with that knowledge as well, is bringing that together, like where the data came from that you were looking for to get, you know, just simple things like IMD. I mean, it seems really simple, but there's a lot of assumptions around that simplicity. If somebody's completely new to this area, do I use tools? Do I use data? This thing about, and I think people are wasting time. I know I've wasted time because I'm learning stuff. And so it was a kind of a request for your methodology or your plans, if not your code, if that's even available, but just to help see it, to generalize it so that we can replicate this elsewhere if needed, or to stop people necessarily. We could do the analysis quickly and then go, hey, we're getting the same results already. So
yeah, good point, Zoe. Yeah, I can't see that would be a problem. I mean, I don't think, I'm trying to think back, but it says the actual evaluation of the pilot. I don't think the analysis was particularly sophisticated. It was mostly done in Excel, to be fair. So I'm not sure what we would share, but yeah, in terms of the methodology and which data sets we used, I'd be happy to include that with the slides, or write it up, as I say, to include with Steve's report on the website, whatever's easiest for people.
thank you.
Thanks, Kate. Thanks, Zoe. So there's just a couple of comments in the chat that I'll read, and then we have a hand up, and we've got time for Chenyu in a minute. So John Adamson was saying he enjoyed the presentation and refreshing to hear talking. These are my words now, sort of candidly about the process, the pros and cons of and the successes and not of what you did, and I guess it must have been quite frustrating as well to not be able to be in control of the people who you wanted to really do a great job and all the rest of it. So really huge thanks for sharing that, and it's definitely something that others can build on and learn from as well. So John says a similar piece of work was done by UHL in Leicestershire, which focused on people on the most deprived areas. Voluntary sector rang up and said to them, we're looking forward to welcoming you next week. Are you planning to attend? So something quite simple. Sometimes it might be not the fact that you've had a phone call. It might be what you've said on that phone call. I don't know what the words were, but again, the detail of what is done is something that people can learn from. It might just be what people have said. So Chenyu, if you still got your hand up, I've got time for you. Where are you? Chen? Okay.
Yeah, I did. Yeah, I didn't mute. Yeah, thank you so much, Kate, for the interesting presentation and the very useful study. And I do appreciate for being so honest about the difficulty in running and deliver the project. And so thank you so much. Yeah, my question is basically about your regression model. When you run the regression model, did you use any like special tools, or you use R, or what the software you use for run the regression model?
Yeah, I'm probably not the right person to answer this, but I know that Carla, who did the regression model, uses R. So I'm
use R.
Pretty sure that she did that on R. Yeah.
Thank you so much. Yeah, I just wonder whether it's possible I reach out to either you or Carla if we locally need to run this model using R. I may ask for some advice or even coding.
Yeah, if possible, if that's possible.